Yeah, welcome everyone. Thank you for joining us this evening. We're just going to wait just a minute or two so that everyone has a chance to join. But thank you so much for joining us this evening. Thanks everyone for joining us this evening. I'm just giving us just 1 minute there just so that everyone has a chance to join us. But yeah, it's good to see everyone, all the numbers going up there. So okay, I think I might just kick off. I'll start off with some introductions first. So my name is Aoife Breslin and I'm the head of marketing and comms for Sims IVF. Sims IVF has been around since 1997, and we have 6 locations in Ireland. So we have 3 kind of main clinics. So we have one in our South Dublin, which is Clonskeagh. We have one in North Dublin, Swords, and we'd also have one down in Cork as well. And then we have what we call satellite clinics, which are clinics that kind of support you through your journey. So they would kind of provide testing and scanning so that you don't have to kind of travel multiple times to the main clinic. So they would be in Dundalk, Carlow and Limerick. We're also part of Virtus Health as well, which is kind of a global provider of fertility treatment. So they have clinics all around the world, in Australia, in Europe and Singapore. And so we're very lucky to have that network of support for ourselves. If you have questions this evening, please pop them into the Q&A there at the bottom and we will do our best to answer them at the end. So tonight we are joined by Dr. Alex Odate. He is the medical director of Sims IVF and he's usually based in our Clonskeagh clinic. So he's going to give a little presentation tonight. And again, any questions, just pop them in the Q&A and we will answer them at the end. So I'll hand you over to Dr. Alex.
Hey, hello everybody. I'm Alex. I'm the group medical director of Sims IVF, and today we are going to have a presentation about all the options that we have for same-sex couples. And in fairness, we are also going to talk about other topics as well, like general procedures that we are doing for doing diagnostics and all this. So first of all, would you please just confirm that I'm sharing my screen there with you and that you're seeing the presentation that is just there? Please just let me know if that is happening. Thank you so much.
We can see it.
Thank you. So, well, I'm Alejandro, but you see in Ireland, it will be easier for everybody to pronounce just like Alex. Okay, so I'm Mexican. I'm a gynecologist and I've been working on the field for the last 14 years. I did my training as fertility consultant back in 2009 in Barcelona in Valdebrón Hospital, which is a university hospital. And I moved to Ireland back in 2017. I've been working in several clinics. But you see, I'm so bad for talking about myself. So, and this presentation, of course, is not about myself. It's about you guys. So essentially what I will do now, I'm going to start with this presentation. And please, as Aoife said, if you have any questions, please just type them down there in the Q&A, and I will be happy to answer all of them at the end. So, well, this presentation is going to cover several aspects of the treatments and several options for same-sex couples. But what is important to understand, of course, is the overview. Of course, all the patients that are coming to our clinic, they have their own journey. And of course, we need to facilitate and we need to give them the best care possible. So essentially, the way this starts is pretty much like this. So is you guys contacting our clinic, filling a form that we call the new patient form. That will be the second step, and sending that on to our team. Then what happens normally is that you're going to get an initial consultation with one of our doctors. It could be myself, it could be Dr. Marta, Sarah, Javeria. It all depends the location that you are looking to have the appointment. And then afterwards, after having the initial consultation, so essentially what we do as your doctors is to Get the medical history. That will be the initial step. It is important to get all the medical background, and we really appreciate when you are sending all those forms, the new patient forms, fill it in, because we understand that sometimes it's a lot of questions and a lot of things that you need to fill down there. But it's important for us to have that information in advance, because the more information we have, the best feedback we can give you, and the easier and quicker we can get the diagnostic. So once we are doing the medical history, of course, we are going to tell you what will be the investigations that we need to do. Sometimes will be about checking the ovarian reserve. Sometimes will be about checking the semen assessment and sperm concentration or DNA fragmentation. Sometimes will be more about checking the womb, the fallopian tubes, the ovaries. Once we know exactly what we doctors we need to do, what we need to check, we pass all this information to our team, the nursing team, which normally is going to contact you, and they're going to schedule all the investigation. And then, of course, once we're having the results and the reports of everything, what we do normally is like a follow-up consultation that we call return consultation. That will be pretty much the fifth stage that you are seeing there. And we prepare a treatment plan. That treatment plan, of course, is going to be a comprehensive approach, given all the background, given all the new patient form, the medical history, all the results and the investigation that we have asked it to do. And then once we put everything together, we prepare the treatment plan and we go ahead with that one. At the end, regardless of the outcome, of course, we want to get all of our patients pregnant, first attempt, first embryo, first transfer, or first insemination. But of course, when this is not happening, so then we will have a follow-up conversation, or even in the event, of course, that this is happening, and thankfully that we are getting there and you're getting pregnant, still you will have return consultations with us for doing giving us your feedback and everything. And that's pretty much the summary of the journey when you put it all together, from square number one, doing the online so the first when you are Googling and you are putting there the fertility treatments, whatever, up to the point of getting the treatment done and the follow-up return consultation. Probably you know this definition or not. However, it's very important just to go back to basics. And going back to basics means to talk about a little bit about what infertility is. Okay, so by definition, infertility will be trying for a baby for at least 12 months, that will be 1 year, without success. But it's true that nowadays, 2023, what we normally do, what we normally tell to our patients is that for couples that they've been trying and they are trying for 6 months and they are over 35 years old, although they don't have the label as infertile couples, we do advise to have an initial consultation with one of our doctors to get, of course, all the feedback, to get, of course, all the medical history, and of course, the assessment that is required, okay? I do understand that when it comes to same-sex couple, well, we are not seeing you as infertile couples or infertile patients, of course, but still, it is important for you, because you never know, you can have family or friend that can be suffering this, and for that reason, I said if I'm going to stick to the presentation that we have, because it's important for everybody to know definition about infertility, and it's very prevalent. You see, it is 1 in 5, so it's very, very prevalent. And of course, it could be secondary or primary. It all depends if that particular couple that we are talking about, they have previous children or not. I really would like to touch this topic because it's very, very relevant, okay? Age does matter, and age does matter for everybody. Age does matter for men and women, okay? So the thing here is that the ideal years for having babies and getting pregnant, definitely they will be under 35 years old, okay? So essentially what we know now is that around 40 years old, all what is related to fertility when it comes on female side is pretty much gone. And I know that is very kind of shocking, But because you see, sometimes we doctors, we have told you that, well, if you're having menstrual periods, you are fertile and all this. But you see, we were wrong. We absolutely were wrong, because what we know now is that fertility is dropping every year for everybody, again, including men as well. And what we know now is the ideal will be in between 20 to 30 years old, and up to 35, you are still kind of safe. But 35 to 40, it will be difficult, very challenging, and above 40 is very challenging indeed. Okay, so again, this is important for everybody to know. And men, we are not that far away from this as well. So you see, when I've been trained as fertility consultant, again, 14 years ago, I've been told, Alex, don't worry, you know, man, a man can have babies up to 70, 75, 80 years old, but we were completely wrong, okay? So nobody can be like Mick Jagger, so believe me. So it is also very important to get pregnant younger rather than older, okay? And the reason is because, of course, also men, we are losing sperm concentration, motility, morphology, all this during years. So essentially, best years also for getting pregnant for men will be the same as women under 35 years old. And it could be up to 40, 45 years old, but no kind of older ages compared to that one. Okay, so what we normally, doctors, what we do, we follow an algorithm. We follow an algorithm to kind of find out what the problem is. And when we're talking about same-sex couples, what we do is the full assessment on both sides, for instance. So what we do is we check generally speaking, we check the egg, we check the sperm, and we check the housing, which means we do all the investigations related to egg quality and quantity as much as we can. Of course, quality, it is more given by age, as you pretty much probably know, but it's important as well to check quantity. And that's something that we can do with the AMH, and that's something that we can do with the AFC, also known as antral follicular count, and the AMH stands for anti-Mullerian hormone. That's the initial assessment that we normally do for female. Also on male side, we check, of course, the semen assessment. Okay, so in the semen assessment, we can get information about volume, about sperm concentration, about motility, and about morphology. And these are pretty much the most important parameters when it comes to fertility. And the most important overall will be definitely sperm count, sperm concentration. So once we have an idea about what's going on with the egg side, with the sperm side, also is very important to check and have a look about the housing. And when we are talking about with housing, will be, of course, the womb, the uterus. So there are several ways of doing the assessment of this. One of the most common ones will be an SIS, also known as HICOSI, or also known as saline infusion sonogram, which essentially means to do an internal scan, and after, of course, for measuring the uterus, for checking the fallopian tubes, for checking the ovaries. And after doing that assessment, what we do is we pass a catheter inside into the womb, and we are filling up the womb with water. This is important because with this SIS, we can rule out polyps, fibroids, and we can check this, the size of the cavity, the position, and pretty much everything. At the same time, we're using a foam contrast, so we can check, of course, also the patency of the fallopian tubes. So with this full assessment, we are in a much better position to know what the problem is, and we are in a much better position to find out what is the problem if we are talking about an heterosexual couple looking for a pregnancy. When it comes to a same-sex couple, the assessment is kind of similar, but of course, if we are talking about two female, what we do is we check the eggs. So we do the AMH and AFC, and something that is called FFP, female fertility profile. And also we do the SIS on both sides. Why? Because with this assessment, we are in a much better position to tell you, well, what are the difference? And we can do, of course, a comparison in between, of course, AMH and AFC. And of course, we can tell you more information about feedback, about suitability of being, for instance, recipient or being a donor, or the possibility of both of you getting pregnant, for instance. So this is the initial assessment that we normally do. As I was telling you, we follow an algorithm. Regarding the investigations, again, when it comes to checking the ovaries and when it comes to checking the ovarian reserve, and this is an important concept that you need to understand. So the ovarian reserve that is here with the AMH, it is a concept that is important because what you probably don't know is that a female, when you born with a specific number of eggs. For instance, men, we are producing a sperm every 72 to 90 days. So for instance, the sperm that I'm producing today is going to be ready to rock in 3 months' time. But female, you are different. So you're born with a specific number of eggs. That number was calculated, or it is calculated in around 2 or 3 million of eggs. But then when you start with the menstrual period, that number drops to 500,000 eggs. And then, of course, every month, regardless if you are trying for a baby or not trying for a baby, you are going to spend anything in between 500 to 1,000 eggs per month, okay? And some of my patients, they're telling me, hey, Alex, you know what, that's not accurate, because what I read is that we are having the ovulation only by one egg. And that's true. The final ovulation is by one egg. But if you go to this chart here, you're going to see that, yeah, there's the follicle here, there's one ovulation, but believe me, there is other kind of, a lot of follicles there that they are pushing the one. Those could be like 400 or 500 that they are pushing the one to be ovulated. And those ones that are pushing the one to be ovulated, unfortunately, you are not going to get them back. So long story short, every month you are spending anything in between 500 to 1,000, okay? And this is given by genetic, and no doctor can tell you exactly, oh, sir, you are spending 463 follicles. No, we don't know that information, okay, in that detail. But what we know is that it's anything in between 500 to 1K. For that reason, it is important to do this assessment, which is the AMH. And with the AMH, the anti-Mullerian hormone, we cannot tell you exactly your number, okay? So we cannot tell you exactly how many eggs you have left. So the way it works is slightly different. So what you are seeing on this chart, okay, in the y-axis, you are seeing the concentration, and in the x-axis, you are seeing age. So the way it works is quite simple. So for instance, if we are getting an AMH level of 20, and the patient is 32 years old. So we go here. Where's my mouse there? We go with the mouse here. Yeah. And then 32 years old, 20, and it will be something around here. Okay. And that will be a great AMH, by the way. So please note that having a really high AMH, not necessarily it is good news, because as you can see here, having a really high AMH, like for instance, in the same example, 32 years old and an AMH of 50, potentially could be PCOS, okay? So essentially what we would like to see is that all of our patients, they are falling in this kind of orange-ish or yellowish kind of frame here, okay? And again, the way of doing this is just very simple. You come to the clinic, you have a conversation to one of our doctors. So then we are requesting a female fertility profile. The female fertility profile is going to have some investigations like the ones that you are seeing there, like the thyroid function, the prolactin, the full blood count, testosterone. And at the same time, we're going to check for this one. With this number, you're going to have a return consultation. So we will be in a much better position to tell you where you are and what to do. And the reason why I'm time with this, with the AMH, is because once we have this one, once we have the updated AMH, by the way, because it's important to have a recent AMH, for instance, if you have an AMH that was carried out 2 or 3 years ago, very likely is that I will need to repeat the AMH to have an updated one. And the reason is because with this one, we doctors, and of course with the rest of the assessment that I just explained you, we do take decisions with this one. Treatment, for instance, IUI, IVF, medication, for instance, HMG, Menopur, Gonal-f, which is recombinant FSH, and also dose. And also the AMH help us to give you expectations, how many follicles, how many eggs, the probability of getting 3 blastoses, success rate. For that reason, this investigation, it is crucial to know exactly where you are and what is the best course of action, okay? Yeah, so ovarian reserve, as we were just saying, could be normal, could be high, or could be low, okay? So when it's low, it's something that we call low prognosis patient or diminished ovarian reserve. But by the way, it is not a deal breaker, and this is very important to highlight. Sometimes patients are coming to my office, oh, Alex, you know what? They told me that my only option it is egg donation because I'm 39 and my AMH is only 2. Well, not necessarily. I mean, potentially means that the probability is going to be diminished, but it's not impossible, okay? And it's important because, of course, if you don't try, that's, of course, 0% chances. But if we try, we definitely will have some chances at least. But it's important to manage expectations. That's true. And it's important for you to understand where you are and what will be the best treatment option. Okay, the SIS that I was just explaining you before, the saline infusion sonogram, it is for checking the cavity, what you are seeing there on the screen. It will be the womb, the uterus. Let me just go with the mouse here with the arrow. Okay, so this will be the uterus here. And this is the cavity of the womb. As you can see, it's very smooth, it's very homogeneous. So that means that there is no polyps, that there is no fibroids. That's exactly what we would like to see, that all the cavity, it is clear. And then here, when we are passing the foam contrast, that foam and the ultrasound is going to look like white, okay? So this part here, if you follow the arrow there, that will be the left fallopian tube. And we put it there on the ultrasound like LT tube, which means left tube, okay? Yeah, it's important to get this assessment because otherwise we will assume that the fallopian tubes are fine, and of course that the polyps, that there's no polyps or fibroids, for instance, and that can be wrong, okay? Because fallopian tubes, they can be blocked without any kind of without any kind of manifestation. So sometimes they can be blocked just because. I mean, they can be blocked because of an infection, but that means not having fever, not having vaginal discharge, nothing, just being blocked. And it's only when you are trying for a baby, or for instance, when you are trying an insemination and nothing is happening. And then when we are doing the assessment, we are finding out this. For that reason, we prefer to do it the other way around. Rather than you trying and then finding out that it's not happening, we prefer to do the assessment first, so then we can tell you what's going on. Yeah, so there's few things, of course, that are on your side as well. I was just explaining so far what we are doing, the algorithm, the investigations, and all this. But this is also important for you. I mean, it's very, very relevant for you to be, to be healthy. I mean, this is like a teamwork. We help you, but we also need that you help us, okay? So essentially, yeah, so what we would recommend, for instance, if possible, to cut off all smoking. Smoking is very harmful for the eggs, is very harmful for the sperm, particularly for the motility of the sperm, and also for the DNA fragmentation, the quality of the sperm, the inside quality, okay? Alcohol, well, as well, unfortunately, it is not recommended in preparation for an IUI, IVF treatment. Egg freezing treatment is not recommended. And what we will recommend, it will be to cut it off. If it's not possible, so then less than 10 international units per week. So that would be roughly like 3 or 4 in a week, okay? Beers, pints, or glasses of wine, okay? And then coffee, we will recommend only 3 caffeine coffees a week. I know that's painful. I also love coffee, but that's the recommendation. And of course, exercise, very important as well, will be the BMI, okay? Because with the BMI higher than 30, of course, probabilities of having, complications during the pregnancy are more prevalent. And also very important will be complications such as miscarriages, okay? Also, you are seeing there on the screen some vitamins. Look, it's not like I recommend any particular trademark. Vitamins are just vitamins. The recommendation, a multivitamin, okay? And that taking that consistently, which means 1 tablet per day. Again, just 1 preconception vitamin will do the job, okay? There is other kind of supplements that we doctor use, but those supplements should be under kind of supervision, such as CoQ10, such as DHEA, such as omega-3, also testosterone gel, for instance. I'm not saying that you cannot take them, but of course, if you're taking them, it is important to always do this under medical supervision. Okay, treatments. We go with treatments here. Well, this is important as well. In Sims IVF, we're working with Cryos. Cryos is the sperm bank that we work with. To be honest, is one of the best sperms banks in all Europe. Okay, we've been working with them for a long time, and we're having fantastic and amazing success rate. The Cryos bank, it is based in Denmark. Of course, there is a process. Once we decide what treatment we're going to do, for instance, IUI with donor sperm, for instance, IVF with donor sperm, what we do is that we send all the information to one of our nurses. Her name is Deidre. She's going to contact you, and she's going to explain to you all the details about how to request the donors, what is the paperwork that you need to do, how long it's going to take to get the donor sample into the clinic. If I'm not wrong, it will be something in between 4 to 6 weeks. So that's the reason why it's important. One, we agree, doctors and patients, we agree a treatment that we want to go ahead with to just order the donor sperm sample as soon as possible, of course, to avoid as much as possible delays. Okay. Yeah, all the relevant information with the donors. You can find out more information in our website. You also can go directly to Cryos, the sperm bank in Denmark. And if you have any questions, please just let us know, and I'm going to kind of contact my team so they can come. Yeah, this is also very important. Back in May 2020, COVID year, the legislation in Ireland has changed, okay? And if I'm not wrong, it was the 5th of May, okay? But essentially, the change on the legislation is prior to that, like 2019 or 18, we were being able to work with identifiable donation or anonymous donation, okay? Whereas now, Ireland is heading pretty much in the same direction as UK, and nowadays, the only possibility will be identifiable donation. And this is applicable not only for sperm, but also for eggs, okay? So essentially, this does means that once you are proceeding to a treatment, regardless if it's an IUI or IVF, we strongly advise to do a counseling session that is actually SIMS advice, and at the same time, it is the HSE advice for you to have a counseling session, just to be 100% sure that you know, well, what are the implications of proceeding to this treatment on your own, okay? That's that. And the other thing is that, well, that once we are receiving that report from the counselor, we get the ball rolling with the treatment. But the other thing that is important here to highlight is that, well, the information about the donor, and I want to be clear with this one, is not going to be for you as single lady or you as a couple, same-sex couple. I mean, you are not going to get the information about his name, his date of birth, and all the medical history. Is not the way it works. So essentially, that is going to be kept on the Department of Health. So then when your future child, it is reaching 18 years old, he or she is going to be entitled to go directly to the Department of Health and request this information. If that is the case, okay, if that is the desire. And that's the way it works. So essentially what I'm trying to say here is that the information is not going to be for you, but it's going to be pretty much for your future child. Okay, so the treatment options that we have, as you probably know, we are talking about an IUI with donor sperm. IUI stands for intrauterine insemination. IVF with donor sperm. IVF means in vitro fertilization. Social egg freezing, which to be honest, nowadays is very, very common treatment. And shared motherhood, also known as reciprocal IVF. I'm just going to give you a general overview about what the treatments are about, okay? I'm not going to tell you all the kind of the details, but it's important for you to have a general idea about what these treatments are about, okay? So the IUI, what we normally do, it is with the menstrual period of the partner, of the female partner that is entitled, it is intending, looking for the pregnancy. What we do is with the menstrual period, we give her medication, okay? That medication can be oral tablets, or that could be also as well injections, like subcutaneous injections. That is roughly for 10 days, okay? During those 10 days, that female patient is doing the treatment, is doing the injections, taking the tablets. At some point, we're bringing the patient in. We are doing a transvaginal scan. We are checking the development of the follicles. We are checking the follicles. We're checking the ovaries. And of course, once we are seeing that a good quality and good size follicle is there, meaning 17, 18 millimeters and everything good with good thick lining and everything, what we do is we administrate the final injection, that's the trigger shot, and 24 to 36 hours after that trigger shot, what we are telling you is like, you need to come here to the clinic. Once you're at the clinic, so we are thawing out the donor sperm sample. We are preparing the sample, so we spin the sample, we select the best swimmers, and then transvaginally we place them inside, as you can see there on the screen, we place them inside into the womb. For that reason, we are talking about uterine insemination. And because of the fact that we are giving you medications, we are doing the follicular tracking, we are triggering the ovulation, we are selecting the sperm and placing the sperm at the right time in the right spot, because we're doing the 5 of this. So the probability of getting pregnant is going to be higher compared to trying at home naturally, for instance, okay? So the overall success rate, it will be 20 to 25% chances having the pregnancy test positive, and anything in between 18 to 23% chances having the baby at home, okay? This treatment, it is ideal for single ladies, for couples as well, same-sex couples, that of course there is no problem of infertility. It's just like there's no sperm, that's it, okay? But it's important to highlight that I'm telling you 23%. I mean, it's not like we are talking about like 70 or 80% chances of getting pregnant, unfortunately, with one attempt. But makes sense, of course, for patients, as I said, same-sex couples or single women, of course, when they are under 37, 38 years old. Above this age, it's not like we will tell you, no, you cannot proceed to the IUI with donor sperm. We will never do that. But definitely the recommended treatment, the recommended option will be IVF, because the probability above 38 years old can drop a little bit. So of course, it's just like, you see, we need to balance the risk and the benefit. And probably at that age, it will be better to proceed with a treatment that, of course, you can get a higher success rate. So that's the IUI, intrauterine insemination, the overview with donor sperm. And of course, please, if you have any questions, again, just drop those questions in the Q&A, and I'm happy to answer those at the end. Then we have the IVF, in vitro fertilization, which in a way, to be honest, it's similar to the other treatment that I just described there, the IUI. What are the difference? I'm going to explain you all that today. So essentially, with the IUI, as I was telling you, day 1, day 2, menstrual cycle, start with injections, 10 days, doing one scan, trigger shot, getting the sperm, putting the sperm sample in. That's it. And then, of course, waiting for the pregnancy test, which is another 14 days. In the IVF, it is similar, but the difference is that, number 1, we increase the dose. Because you see, in the IUI, the aim of the treatment is to develop 1 or probably 2 follicles, but we are not aiming, we don't want to get 10 or 15, okay? So for that reason, the medication that we are using is just tiny. It's just like letrozole 2.5 or Gonalev 50 international units only. But when it comes to IVF, in order to increase the probability of getting you pregnant, we need to get a really good number of eggs, meaning 10 to 15 if possible, because sometimes when the AMH is low, we are not able to get that number with one round. But that's what we are aiming. So for that reason, instead of using 50 international units, what we use normally is 150, 200, 300, and even 450 international units to maximize the ovarian stimulation. So the process is similar in injections. So then having most of the times 3 appointments, which are cycle day 1, cycle day 7, cycle day 10. We do the assessment, same story, transvaginal scan, checking the ovaries, counting the follicles, and then we're telling you, continue the same, rescan on Friday, trigger on Wednesday, whatever. So we tell you the instructions, and then 36 hours after the trigger shot, instead of taking the sperm and putting the sperm sample in, we are doing this the other way around. In the IVF, what we do, we are taking the eggs out, okay? So we are harvesting, we are doing the egg collection, okay? So then once we're having the eggs with us, so then we are towing out the donor sperm, we're putting with the eggs together, and we are getting embryos. Remember, egg and sperm, and when they get together, we are talking about embryos. Of course, this process has five stages, and you can see there on the screen. What I was telling you was the ovarian stimulation, which is normally the second stage. The first stage will be the preparation. Then the egg collection is when we are harvesting. That's the third stage. Then we're putting them together, and then there's the embryo development, fourth stage, embryo transfer, and then finally the pregnancy test, the fifth stage. It's important for you to know that when we are doing the harvesting, the third stage, that one, it is under sedation, okay? So essentially what we do is like once we have done the second stage, the 3 scans, we are seeing the follicles and you are ready to rock, we trigger, and then 36 hours after the trigger shot, you're coming into the clinic, we are placing a cannula in one of your veins, and we give you a combination of medication. 50% of the patients, they completely fall asleep. The other 50% of the patients, if they are not completely full asleep, they are going to be very relaxed, okay? So the procedure, it is not painful. It is true that some patients, they are experiencing the kind of pressure because of the ultrasound, the prop that we are using, but not pain as such. So then once we're doing the egg collection, on the day, if it's myself, Dr. Marta, Javier, Sarah, we're going to tell you how many eggs we have retrieved. If we're talking about 10, 12, 13, 14, whatever the number is. And then the day after the egg collection, when we are putting together with the sperm and we are doing the fertilization, that's there on the 4th stage there that you are seeing there. So my team, the laboratory, is going to come back to you and they're going to let you know how many of the eggs that we have retrieved are fertilized. So that means how many embryos you have in total. Then most of the times the plan will be to transfer 1 embryo at a time. Again, remember what I just said. If we are talking about same-sex couple, you are not infertile. So the problem of transferring 2 embryos, it is that if the 2 embryos are good quality, it's very likely that you can get pregnant with twins. And you see, some of my patients, it's funny because some of my patients like, Alex, but that's good news. I mean, 1 shot, 2 babies, we close the factory, that's it, right? But no, the problem with that is that, well, automatically, if you're getting pregnant with twins, you are going to be like classified as high-risk pregnancy, as you probably know. Also, more probability of having high blood pressure during the pregnancy, like 15% more chances, 10% more chances of having gestational diabetes. And fair enough, you can tell me, okay, Alex, but you can treat that one, right? Like you give me tablets or whatever, and then that's sorted. Yeah, in a way it's true, but what I'm concerned about, it is 8 to 10% more chances of premature delivery. And there's nothing that we doctors can do about it. And I'm not talking about 32 or 34 weeks twins. They're going to be gorgeous, so no problem with those. I'm talking about 25, 26 weeks of pregnancy. In fairness, in Ireland, they're going to survive, but not necessarily completely healthy, you see? So for that reason, my recommendation, unless there is a medical indication, will be to keep things simple, okay? Transfer the one, and if you have more embryos, get the other embryos frozen. So nowadays, in my clinic, in Klonsky, and also in Swartz and Cork as well, if not the same, the frozen embryos can give you a slightly better probability of getting pregnant. You just can Google that one. You're going to see that many of the clinics, they are heading to freeze all the strategies to everybody, because if not the same, it could be a slightly higher success rate. I'm not saying that we necessarily need to do that, but what I'm saying is like, do not worry about freezing embryos. Okay, so then social egg freezing, well, as I was telling you before, it's very common practice nowadays. And the reason is because this is the way I'm saying this is like a plan B, okay? So particularly for single women, so essentially it's just like sometimes, well, life is life and they haven't met Mr. Right, and that's completely fair enough. And you see, but the thing is like time is ticking for everybody, including myself, including all of us. So the thing is, like, if you don't have something as plan B, the probabilities are that if you're not meeting someone, and then of course all the time that is going to get pregnant and everything. So yeah, this is the way of seeing this. Is like not like our insurance policy exactly. I know that that's what is written down there, but the thing is like, it's the plan B. So essentially, what we do, it's similar It's similar to the IVF cycle. So essentially it is, well, the preparation, the ovarian stimulation with the injections, the 3 scans, the trigger shot, and the egg collection. So up to the point of the egg collection, the social egg freezing, it is identical to the IVF cycle. And this is important for you to know, because you see, well, it's many patients is like, hey Alex, and then what happens after 2 or 3 years that I want to work with the embryos, with the eggs, sorry, that are frozen? So it is not as easy as you are coming into the clinic and then we are throwing out the eggs, we're putting the eggs in, and then, okay, go back home and have sex with your partner and you're going to get pregnant. Not at all, okay? It's not the way it works. So essentially the way it works is like, once we have the eggs frozen, in the future, if you want to work with the eggs that are frozen, we will need to finish the IVF cycle. So essentially, we will need to thaw out the eggs. We will need to get your partner's sperm. We will need to kind of doing a fertilization, or as well, the donor sperm, we will need to do the fertilization with ICSI, with ICSI, letting the embryos grow and then doing the transfer. So essentially, we will finish these 5 stages that I previously explained. This is important to know because sometimes patients are with the understanding that it's going to be just putting the eggs back and that's it, but it's not the case, okay? And by the way, the recommendation here will be, if, for instance, you're getting 14 eggs frozen, amazing, and then you have the donor sperm, the recommendation will be to thaw out all of the eggs, getting the donor sperm, doing the fertilization, and transfer 1 embryo. And again, if you're getting more embryos, to get those embryos frozen. Sometimes it's like, oh, Alex, but you see, my egg was frozen, then my embryo is going to be frozen, so definitely it's not going to work. It is not the way it works, okay? Because it's different freezing eggs to freezing embryos. That's very important for you to know as well. So freezing embryos, they have a survival rate of 98. So pretty much all of the embryos that we're getting frozen, they're going to survive the freezing and thawing process. Whereas with here with Julian and Graham, we have a fantastic 92% survival rate. Other clinics, they have lower than that. But what I'm trying to say is like the standard across Europe, it will be 70 to 80, 85, or even 90, okay? But the long story short, it is that eggs, they unfortunately do not survive the same way as embryo does, okay? So it's important for you to know this. Okay, and also this is a fantastic treatment. Not all of the clinics in Ireland, they have this license. I'm very happy that we do, because it's a fantastic treatment. So essentially the shared motherhood, what we do is like, well, or reciprocal IVF. We do the assessment of the couple, of the same-sex couple, both partners. As I was telling you, we check the eggs, we check the AFC, we check the fallopian tubes, we check the cavity. We do the assessment on both sides. So then we talk to you and we are telling you what will be the probabilities if we are working with, let's say, A and B, if we're talking with A, X, and then put it on B, or the other way around. So donor and recipient. It's very easy to do once you understand the process. So essentially, the way it works is like this. Once you're coming into my office and we are doing the assessment and we are agreeing who is going to be the donor and who is going to be the recipient. Spoiler alert, we normally go with whoever is younger. We will recommend you to be the donor, okay? But we can do it the other way around if that is not your plan, okay? But always, all of my doctors, we are very upfront to telling you what are the success rate working with A, working with B, okay? So then once we are agreeing who is going to be the donor, who is going to be the recipient, and the assessment is carried out, I prepare a treatment plan, I send that to my team. So then we start with the donor. Starting with the donor means that particular partner is going to be considered as a donor, need to do the counseling, need to do all the assessment as donor as per the European legislation. So then she's going to be the one who is going to do the first stage of the treatment, which is doing the ovarian stimulation, doing the scans, doing the egg collection. So then at that, we're getting the sperm, we create the embryos, and then we let the embryos grow up to the blastocyst stage. There is 2 ways of doing this. Both of you can be on preparation. Both of you can be like one doing the IVF treatment and the other partner being in preparation of the lining of the womb for receiving the embryos fresh. To be honest, it's not my recommendation because both of you are getting a lot of hormones And then the thing is, like, sometimes there could be like, oh, she is not ready, but she is. And then what we do with the embryos is very stressful for you girls. The recommendation nowadays, 2023, will be working on one side, getting the eggs, creating the embryos, and getting the embryos frozen. And once they are frozen and everybody is fully recovered, so then we work with the recipient. And working with the recipient means doing the medicated FET, which is preparing the lining, doing the assessment, towing the embryo, and transfer the embryo back. Because remember just what I said, fresh and frozen, if not the same, frozen is slightly better. Okay, so if you were my sisters, I do it that way. Working in one side, getting the eggs, getting the embryos, getting everything frozen, and then working on the other side for doing well, the medicated FET or stimulated FET, which means medicated frozen embryo transfer. Success rate is going to be given by AMH and age of the partner who is working. I don't like that word, but well, who is behaving as the donor. Okay. Yeah. So and that's very relevant for you to know, I think. Again, if you have any questions regarding the shared motherhood, please let me know. Yeah, so this is very, very relevant slide, I think. So when we are talking about treatments, fertility treatments, we need to be sure that we are explaining you that there's always the financial cost. Of course, money does matter. Physical cost, psychological cost, and emotional cost, okay? And here in SIMS, we are very conscious about that. So that is the reason why we try to inform you as much as possible. That is the reason why we teach treatments. That is the reason why we explain you every single step. If it's required like 2 or 3 months, we will take the time. It's important for you to understand not only success rate and what is the cost, the money-wise. It's very important to understand that this is very challenging and the journey, it is tough. Doing the injections, coming to the scans, and then of course you have a life. And then you're like, oh my God, but I have to work this day, and then I have the echo action, and what is going to happen? So we totally understand that. So for that reason, please, when it comes to treatments, regardless if we are talking about IUI, egg freezing, IVF, or shared motherhood, it's very important always to be in a very good position regarding the far costs before starting with treatment. Yeah, so that's pretty much what we were just saying before. Yeah, we recommend as well to have emotional and psychological support. We have, I mean, not on site, but we have a counselor that we work with. Look, believe me, I also do counseling sessions once a month. Otherwise, I will be crazy. You see, it's for everybody. I mean, it's a really, really tough process. So definitely getting all the support that is required, it is important, and we can provide this for you. Yeah, it's important as well, this. We always want to get our patients pregnant with the first treatment, the first embryo, the first transfer, the first insemination, because of course, I mean, we that's what we are aiming, and that's what we are planning when we're doing a treatment plan. Not always is the case, and that's true. And I need to be honest in telling you this. But what is important for you to understand as well is that patients who are who are determined, and that they are resilient during the process, most of the times they get there, okay? And particularly when we are talking about same-sex couple, where again, we are not talking about infertility, okay? We are talking more proactive patients, proactive people that are looking for pregnancy. And for that reason, most of the time, the probability and the success rate are slightly higher, okay? So I really hope that you have found this session informative. I'm very happy. I'm very glad. And again, I really want to thank my team, marketing with Katie and Aoife for this opportunity. For me, it's always a pleasure to be here with you. And yeah, if there's any questions, I'm very happy to answer the questions back. Okay.
Thanks so much, Dr. Alex. I think we had one question come through already. So there was just one lady asking if SIS is required before IVF. She has no known fertility issues and she's planning treatment with ourselves this summer. And yeah, she just is wondering, is SIS required?
Yeah, that's a very good question, a very interesting one. It is not mandatory. It's not like, oh, you have to do the SIS for proceeding for an IVF. but it still will be recommended. But I totally understand what is the reason behind the question. It is true that for an IVF cycle, we are not going to work with the fallopian tubes. So most of the times it's like, well, we can proceed without that assessment. But in fairness, if time is not a problem, so I will definitely recommend to have that assessment done. And the reason is because many times during the ovarian stimulation, after cycle day 7, after cycle day 10 of the ovarian stimulation, when the follicles are ready and we're going to do the trigger and the collection, it's like, oh, there's a polyp here. Oh, there's a tiny fibroid there that we haven't noticed or something like this. And look, again, at the end of the day, we can get the eggs, we can get the embryos, we can get everything frozen, treating whatever, and then doing the transfer. But the thing is, like, if we are doing that in advance, well, we can tell you what's going on. We can tell you if we are finding polyps, if we are finding fibroids, and we can tailor the treatment plan better for you. So long story short, it is advisable to have that investigation done, but it's not essential, it's not mandatory.
Perfect. Thanks, Alex. Another question here, can you save the sperm for a second child in Ireland? And I think you can, like you can, if you order in a certain amount of donor sperm, you can reserve that sperm, can't you?
Yes, you're right. So yes, you're right. What we would recommend, well, once you know who you want to be your donor, and it depends the treatment that you are doing, of course. It's different if we're talking about an IUI or an IVF cycle. But what we would recommend is to kind of having 2 or 3 samples from the same donor. Okay, so for instance, you can try with an IUI, not successful. Well, you can try with a second one, and the third one you can have always that one as backup for doing an IVF treatment, for instance. But what I'm trying to say here is that, well, when we're doing an IVF cycle, we are getting several number of eggs, like 10, 15, whatever. So we can fertilize all of the eggs with the same sample, so then we can get embryos frozen. So we can transfer one, and if, for instance, the treatment was successful and we still have like 3 or 4 embryos frozen, most likely is that for baby number 2, you will not need to go and buy another sample because you have already the embryos frozen, okay? However, we still recommend you, for instance, if you are planning to do one IVF cycle, well, probably to get 2 samples, because one is for doing the fertilization and doing the first treatment, and you have always the other one as backup. And as Eva is telling us, yeah, if you have one baby coming from a donor, well, we can use, or we can kind of separate the second sample from the same donor as well.
Perfect.
For sibling purposes, yeah.
Yeah, perfect. Someone's just asking the cost of an SIS, and I think it's about €440, $450. It's around.
Yeah, it's less than 500. It's less than 500 for sure. But I'm not the expert on that area, so don't call me on that one. Okay, I have one observation like, oh, Dr. Alex told me this, and I'm like, oh my God, but yeah, but I'm the doctor. I don't know.
But yeah, no, I think I just double checked it there. It's €440 there. So
okay, thank you for that, Eva.
Yeah, no worries. So this person is asking, they want to try get pregnant in 1 year, for example, and how early should they start the IVF process?
Well, if they've been trying for a year, it's important to get the assessment, okay? Because we need to understand what is the reason why they are not getting there, why they are not getting pregnant.
I think they want to do it in a year, so they're saying, yeah. So they're saying, okay, next year we're going to do it. Okay. Yeah.
Yeah, if it's like that, so well, the sooner the better. So always, even if everything seems to be fine, even if we are talking about a same-sex couple that they are both very fit, amazing, and 32 years old, we still would recommend to get the assessment, okay? Because sometimes we just need to be sure that the AMH is fine, the AFC is fine, that there is no polyps, there is no cyst, everything. So even if you are planning to do the treatment in 1 year time, you can still get the assessment, okay? And then when it comes to doing the actual treatment, at least to touch base with us 1 or 2 months in advance. For instance, if you're planning to do the cycle in September, to touch base with us in June, for instance. Yeah.
Perfect, thanks. Just give it 1 more second, see if there's any more questions. I think that's most of the questions. If you do have something that you want to maybe ask offline, or something specific maybe to your own story, then yeah, there's the communication at sims.ie. I'll be sending an email to you by the end of the week as well. If you want to reach out through there and ask any other questions, that's absolutely no problem at all. We can get one of our team to answer those for you. We are also at Pride this weekend, so we will be in Pride Village. We have a stand there. So if you have any questions or queries, pop over to us. We'll have some nurses there. I'll be there. And yeah, any questions or queries, you can kind of come up and have a good chat with us as well. If you're around, we'll also be in Pride in Cork as well, I think on the 5th of August. So again, any questions, if you want to come over and pop over to us, please do. We'd love to have a chat. But if there's nothing else, like I said, email us or chat to us at Pride, and we'll do our best to answer any queries. And many thanks to Dr. Alex tonight. Thank you so much for that really informative webinar, and always learning loads when I pop on these. And many thanks to all of you who attended tonight as well. I hope you learned loads too. So thanks, and have a lovely evening, everyone.
Thank you so much to everybody. Thank you for having me.
See you. Bye.